All right, so let's start by defining what a dysrhythmia is. So a dysrhythmia is any deviation from that normal rhythm of the heart, which our heart should be in normal sinus rhythm. An arrhythmia is lack of a rhythm, so one would think that it applies asystole, but it's used commonly for anything that we don't have a regular rhythm for. So just make sure that your patient, if you're using the term asystole, that means that the heart is not conducting a rhythm at all. Arrhythmia is actually more commonly used than dysrhythmia to describe what we're talking about. So how do people develop dysrhythmias or arrhythmias? So basically, people can be born with them. They may have a structural heart defect. They can be obtained throughout life with after like many conditions, after a heart attack or cardiac surgeries, result of coronary artery disease. Many dysrhythmias do require medical management. Some are not as dangerous. I want to say that honestly, the arrhythmias that cause the most concern for us are those that affect the ejection fraction of the heart or the cardiac output. So this is a sort of a cross-section of the heart. It is showing the conduction of the heart. And what we have here is we start with the action potential of the sinus node that is up in the right atria. And this is known as the pacemaker of the heart. Intrinsic beats are 60 to 100 beats a minute, which you should hopefully recognize as the normal heart rate for an adult. So that travels down through these pathways here and eventually hits the AV node. So the AV node is the only way that that right atria is communicating with the ventricles, right? So the AV node. In the event that the sinus node is not working, the AV node can work. It has an intrinsic beat of 40 to 60 beats a minute. And from there, our electrical impulse that had traveled from the sinoatrial node down to the AV node now goes on the left bundle branch and down the right bundle branch, all the way down to the Purkinje fibers where it causes those ventricles to beat. So the ventricles can also give off a heartbeat. Remember, 60 to 100 beats a minute in the sinus node. The AV node would be 40 to 60 beats intrinsically. And down in the ventricles, we're only at 20 to 40 beats a minute. So you can see how important it is that we have a functioning conduction system. So this picture is of a heart tracing, or what we would see on an ECG or EKG. In it, it basically gives us a visual representation of what's happening in the heart in the conduction system. Again, doesn't tell us the structure, but tells us how well our heart is conducting. So the P wave is the atrial depolarization, or when the atria are contracting. The PR interval tells us how long does it take that beat that is given off by the sinoatrial node down to go to the AV node and into the ventricles. QRS represents ventricular depolarization, or beating of the ventricles. And you can see it's pretty tight and high, and that's because it's a very forceful contraction to push the blood out to the body, where the P wave doesn't have to be so strong because it's just pushing blood into the ventricles. The ST segment, that's where we look at our isoelectric line to see if there's any deviations there. If we have depressions or elevations, that could mean that we're having a ventricular problem, like we've made different pathways, so it's a sign of myocardial dysfunction and potential death of the myocardial tissue. So when we say things like an ST elevation MI, how dangerous those are, that's why. And then the T wave is basically the repolarization or resting of the ventricle as it fills. The QT interval tells us how long does it take for the ventricles to get through the cycle of beating and resting. And if we have too long of a QT interval, that can predispose the patient to dysrhythmias. And if we don't have a long enough QT interval, that means that the heart isn't getting enough rest in between, not able to fill appropriately. A patient will be symptomatic and can also lead to dysrhythmias. So this slide is going to tell us about some of the common dysrhythmias. I'm actually going to move on to the next slide while I still talk about this, so you can hopefully visualize the heart as we talk about these. All right, so our heart rhythm disturbances can be widely defined as those that are coming from above the ventricles or supraventricular. So in these cases, you're generally going to see changes in that P wave. Remember, the P wave was what represented the atrial depolarization. Our ventricular dysrhythmias, those are the ones that originate from down in the ventricles and below the AV node. And when you have a ventricular dysrhythmia, what's going to happen is that you're going to see some changes in the QRS complex. All right, so ectopic foci come from outside of the conduction system, and you'll see them as additional beats or strange beats that don't quite match the P waves and such. And then conduction blocks, you'll see that in our P waves. There'll be changes to the P waves. They may be inverted and otherwise, and changes to how long it takes that P to go through to the ventricle, so the PR interval. All right, so some of the common dysrhythmias that we need to be aware of are atrial fibrillation, which is when the atria are sort of quivering. You'll see up to 300 atrial beats, but again, they're not really very good conductive beats. We have supraventricular tachycardia, so this is a very, very fast heart rate that's originating from above the ventricles. Different types of atrioventricular blocks, so how long it takes the impulse to travel from the SA node to the AV node. PVCs, which are basically the ventricles not taking their turn, going when they're not supposed to. So basically you'll see these wide, sort of bizarre QRS complexes pushed into the rhythm. Ventricular fibrillation and ventricular tachycardia are the deadly rhythms. Ventricular fibrillation, our patient cannot have a pulse, right? The ventricles are quivering, so we don't have cardiac output. And ventricular tachycardia may or may not have a pulse. I often will say your VT patient may have a pulse, but if they do, probably not for long. And so they require intervention, usually by way of defibrillation. So those ventricular rhythms are the ones that we would shock. All right, now after all that background, as we go into these antidysrhythmic drugs, we're basically, there are a lot of them. There's several classes, and I understand it may be difficult to remember them. So we can't remember all the individual drugs potentially, but we can definitely look at them by class. They go by this Vaughan-Williams classification, and there's a picture of Mr. Williams himself, and he was the one that really put it out there how to classify these drugs based on what they do to the action potential of the heart and how they affect these cardiac cells. All right, so here we have the different classes of antiarrhythmic drugs. We have the class 1s, class 1A, B, and C, class 2, which are beta blockers, class 3, potassium channel blockers, and class 4, which are calcium channel blockers. I actually like this one a little bit better because it gives you a mnemonic to remember them and the drugs that belong in there. So our class 1A, double quarter pounder, class 1B with lettuce, mayo, and tomato, and more fries, please, right? So class 1A, 1B, and 1C. Class 2 are our beta blockers, LOL. Class 3, this is sad. And class 4, I and V in class IV or 4. So some things to help you actually remember these drugs. All right, so the class 1A drugs, which would be disopramide, quinidine, and procanamide, these block the sodium channels and delay repolarization, right? So slows it down basically. So we use these for atrial fibrillation, PVCs, VTAC, this thing called Wolff-Parkinson-White syndrome. So that's what those are used for, and we're going to take a little deeper dive into one of the meds, maybe a couple of them. So procanamide has some serious adverse effects in here, and I have them listed. So it can actually cause dysrhythmias, and that's something to think about as we talk about antidysrhythmic drugs, is that most of the antidysrhythmic drugs have the potential to cause dysrhythmias as well. So some of the other things that can happen, diarrhea, this lupus-like syndrome, leukopenia, torsades from the prolonged QT interval. Torsades is a very specific type of ventricular tachycardia. Contraindications to this one, of course, if somebody's allergic to it, has a hypersensitivity. If they're already in a heart block, we don't want to actually slow down their repolarization, and anybody who actually has lupus already. Quinidine, also known as Quinidex is the brand name, basically works on the electrical activity of the heart, and it has an anticholinergic effect. So some of the serious adverse effects you can see here are asystole, so the rhythm can stop, or we can start to have ventricular beats coming in. Now, synchonism. So synchonism is basically an overdose of quinine. So quinine's source is from cinchona bark, and that's where we get the medication quinidine from. And if a person were to have overdose of this medication, they would present with tinnitus, potentially, loss of hearing, blurred vision, GI upset. And a warning on this one, just like the other medication we just talked about, can also cause torsades. This medication, when we give it, even after the condition subsides, it needs to be continued, okay? You don't want to just stop this. So interestingly enough, the phenytoin, the medication that we give for seizure prevention and whatnot, is actually a class 1B antidysrhythmic medication, as is lidocaine. So we use it, phenytoin, we use it in the case of the person having these dysrhythmias from being in digitalis toxicity. So if they are they have toxicity from digoxin, or if they have this long QT syndrome. So that's why we use it there. Lidocaine is used for ventricular dysrhythmias only. And this is not the lidocaine patch that I'm talking about here, folks. This is IV lidocaine. And in this case, this accelerates the repolarization. So lidocaine is helpful to us because it raises the threshold for VFib, right? We would want the patient to have less chance of VFib, so this is what it will do that. It does have some serious adverse effects, including seizures, respiratory depression or arrest, more dysrhythmias, hypotension. It is metabolized by the liver. So anytime we have a person who has liver dysfunction, we would expect that their dose would be decreased by 50%, may be necessary. So if they have liver disease or cirrhosis, and contraindications are here, obviously allergies, hypersensitivity reaction, or if they have a severe heart block already, or some of those more common dysrhythmias, like there again is Wolff-Parkinson-White syndrome. All right, so the class 1C drugs, these block sodium channels, right? That's why they're all class 1, but they really don't have an effect on the repolarization. We do use these for severe ventricular dysrhythmias. Also can be used for AFib and flutter, but not very common for those Wolff, Parkinson, White again, and SVT. So these arrhythmias where we really want to allow the heart to fill a little bit more. Flecainide is the exemplar, one of the exemplars for here. So we use this for AFib and SVT. So why that works for this is it's a negative inotrope and sort of depresses the function of the left ventricle, right? So kind of slows it down. Adverse effects are listed here: dizziness, visual changes, shortness of breath. And here we go. Why we wouldn't use those. If somebody's in a 2nd or 3rd degree block, we don't want to make their blocks worse. If they don't have a life-threatening dysrhythmia, this is not the medication for them, okay? Anybody in cardiogenic shock as well, because we don't want to depress ventricular function in cardiogenic shock. Propafenone or Rhythmol, very similar to flecainide, which we just discussed, but it also has a little bit of beta blocking activity. So this is why it's used for AFib as well. Again, it has to be a life-threatening form, life-threatening ventricular dysrhythmias. Causes dizziness, and some other concerns that patients have is the metallic taste and constipation. So you can read those here. We've discussed beta blockers in some of our other lectures, but our class 2 antidysrhythmics are beta blockers, and they work by disrupting the sympathetic nervous system, the stimulation that it has on the hearts. And when we do that, we also decreases the impulses within the conduction system. These are used for SVT as well as VT, and also for anti-anginals. Some are heart failure. So beta blockers have a wide range of use, and they do have some antidysrhythmic properties in here. So atenolol is going to be one of our exemplars. So this blocks beta 1 more than beta 2, so it's cardioselective, which is good. Remember, beta 1 is in the heart, beta 2 in the lungs. So it's used for more than dysrhythmia. We used it for hypertension and angina, so this one showed up in our angina lecture. And here's our contraindications, right? Beta blockers slow down the heart, so if the heart's already too slow, so severe bradycardia. 2nd or 3rd degree heart blocks, because this can cause further blocks. It's not really used for people in heart failure, cardiogenic shock, or obviously known hypersensitivity. I know we have to keep saying that, but if somebody has a hypersensitivity reaction to a medication, they should not have it. That is a contraindication. So esmolol is another cardioselective, so blocks beta 1. It is really, really short acting. So we use this in the really acute settings for arrhythmias, tachydysrhythmias, and as a reminder, we must have the patient on cardiac monitoring during the administration of this medication. Here we have the old standby metoprolol. So cardioselective beta blocker, though it does have still some action on beta 2. It treats hypertension and also chest pain. And remember the side effects of these medications. Of course, we have here somebody with a low heart rate. Myself, I've used this for many patients following cardiothoracic surgeries and other things where we've already sort of interrupted the conduction of the heart or have the high ability to, so kind of blocks the sympathetic nervous system from being at play there. So now as we're moving on to the class 3 antidysrhythmic drugs, so these are amiodarone and sotalol. So these prolong repolarization. We really use these drugs to treat those dysrhythmias that really aren't responsive. They're difficult to treat. For example, if I have a patient who is post-cardiac surgery and they develop atrial fibrillation despite being on metoprolol therapy, then it's very common that I would the patient would then be started on an amiodarone drip and then eventually put on by mouth amiodarone. So that is one thing. Another thing, so some of these drugs you'll see more often than others. One that I haven't seen too much is dronedarone, but you could see it's kind of in that same class. Amiodarone, dronedarone sound very similar. But the FDA actually put out an advisory about hepatotoxicity related to dronedarone. So I don't know if that's why it's maybe not used as much either, or maybe availability issues, but just something to bear in mind. All right, so let's take a closer peek at amiodarone. So this is the drug of choice for ventricular dysrhythmias. We use it in our ACLS, or Advanced Cardiac Life Support Guidelines. So this says SVY in there. I believe it's supposed to be SVT, so just so you're aware. So we use it for atrial and ventricular arrhythmias. It blocks alpha and beta. And some of the numerous adverse effects of amiodarone are listed here. Pulmonary toxicity, thyroid disorders, bradycardia, hypotension, sinoatrial node dysfunction, can prolong the QT interval, and can cause some blue-gray coloring of the skin. So those are all very, noticeable potentials for this. So does interact with digoxin and warfarin, and contraindications include, of course, hypersensitivity, severe sinus bradycardia, or anybody in a second or third degree heart block. All right, so a couple little things, some other drugs here. We have Corvert or ibutylide and sotalol beta pace. So these medications are used for rapid conversion of AFib to flutter. So ibutylide is based on body weight, but again, both of these can cause ventricular dysrhythmias as well. Sotalol has some beta blocker actions to it as well, as you could probably tell by the name sotalol, because it is a beta blocker. But remember, with our classifications of antidysrhythmics, it's looking at where it's working in the conduction cycle and the action potential. All right, so difetilide or Ticcasin. That's something that we still do occasionally for our patients who are really treatment refractive, so that they're not getting good relief from all of their other medications for their dysrhythmias. So you have to have a special license to prescribe this, and it is pretty dangerous for the patient to have. So for somebody to get started on this medication, they are admitted to the hospital for generally 3 days on telemetry, so that we can see what their heart is doing with the med. All right, because what it can do is cause torsades and SVT, headaches, dizziness, chest pain. So those are all potentials. So the little picture of the nurse with the lady in the hospital is just showing you that you must be hospitalized to get this. In fact, in my hospital, when we know a patient is going to be starting on this medication, we schedule their admission and get them started. All right, so our calcium channel blockers basically inhibit those calcium channels, reduce the AV node conduction, and these are used to help those arrhythmias with SVT, kind of control the rate on those atrial dysrhythmias, so kind of brings that pulse down. Let's take a look at the ones that are common. All right, so diltiazem or cardizem is used frequently in the hospital setting when a person is admitted with atrial fibrillation with rapid ventricular response, or develops that at some point in their hospital stay. So this is a continuous infusion after we give a loading dose, potentially. So when the person is on this strip, we try and get them situated, make sure their heart rate comes down, that they're able to get good cardiac output. And then, of course, you see here the contraindications. So here's that Wolff-Parkinson-White again, severe low blood pressure, if they're in cardiogenic shock, if they have a sick sinus syndrome, or in any of those dangerous heart blocks, second or third degree heart blocks. So verapamil is one of the medications that really works on the AV node. And diltiazem is available as a pill. Verapamil is available as a pill. So basically, it helps control the rate in SVT, atrial fib, and flutter. Treats angina, hypertension, cardiomyopathy. So pretty decently common med that you'll see out there. So verapamil. All right, so adenosine is unclassified, okay? So it doesn't really belong to any of these other classes, but we do need to talk about it here because of how it works and what it does. This is one of the medications that we give to convert paroxysmal supraventricular tachycardia, hopefully back to a sinus rhythm, right? Slow it down. This is the most massive Control-Alt-Delete hard reboot of the heart that we have. It's sort of like chemical defibrillation, if you will. Because remember how defibrillation works. It actually works by stopping the heart and hoping that the electrical conduction system will reorganize. So when we give adenosine, this is sort of the same deal. So when we give adenosine, it's by IV. It has a very short half-life, about 10 seconds, which means that it has about 10 seconds to get from the vein to the heart where it's going to exert its effect. And that's not very long. So you've got to push it hard, push it fast, and flush, flush, flush behind it. And what you have happen here is the person will go into asystole. And let me tell you, that's a lot of pucker power right there, right? As you're waiting for that patient's heartbeat to come back online. But other than that, not too many other side effects besides stopping the heart. And fingers crossed it starts again. Okay. All right, so let's get into some of the nitty-gritty about our antidysrhythmics. So a reminder that all antidysrhythmics can cause dysrhythmias. You may start with one dysrhythmia, which in retrospect didn't seem so bad to the one that you've created by giving the patient the medication. There's always potential for hypersensitivity, lots of GI disturbances, prolongation of the QT interval. If somebody's on Coumadin, you would want to monitor their INR because of the effects that these drugs have and interactions with warfarin. Grapefruit juice should be avoided with amiodarone, disopramide, and quinidine. So add that to your list of drugs we shouldn't take with grapefruit juice. All right, you got to make sure that we have a thorough drug and medical history for our patients that are on these medications. Make sure we're looking for potential interactions, things of that nature. Make sure we have baseline blood pressure, pulse, INO, right? Because some of these meds have effects on heart failure and cardiac rhythm. People should always have baseline EKGs, even potentially further testing like echocardiograms. Look at the serum potassium levels, right? Some of these have interactions with potassium. During their therapy, it says right here, and we really mean it, right? We've got to monitor their cardiac rhythm, heart rate, how they're feeling, skin color, right? Perfusion, listen to their heart and lungs. Some of the drugs may need plasma levels, and if that's the case, then we need to monitor those and looking for any toxic effects. All right, we need to provide appropriate patient teaching instructions for those who are taking antidysrhythmic drugs. Do not crush or chew any of the extended release forms. A lot of these who have the GI effects, we can sometimes lessen those by taking the drug with food. Limit caffeine. We need to teach the patient never to double their dose and not to take the meds with antacids. And some of the medications can actually be digested through the stool, and looks like the tablet or the capsule is still in the stool. When it comes out, they say, oh, this isn't working. I've just pooped it out, right? But actually, that's the wax matrix that's carried the medication. The medication was absorbed. So that might be something to tell the patients that they shouldn't worry too much about there. And remember that we need to have EKG monitoring for looking for things like a prolonged QT interval. especially with these drugs listed here, because they can all prolong the QT interval. We always want to use an infusion pump, right? This is not one of those drugs that we're trying to figure out drops per minute. Let's be very specific and put them through the IV pump. That is safety. Anything that has lidocaine and epinephrine are not to be given IV. Sometimes when you are working, there'll be in the Pyxis or otherwise, the provider may order this lidocaine with epi, and that is for local anesthetic for the skin. Be very careful not to confuse the two. All right, so and remember to look for the therapeutic response in our patients, right? If we're giving these antidysrhythmics because of hypertension, we want decreased blood pressure. We want their edema to improve, decreased fatigue. We want their pulse rate to become regular, or without major irregularities or improvement. We want improved cardiac output. And if you've made it this far, congratulations, you finished the lecture on antidysrhythmic drugs. Left you once again with a cute little cartoon, so I hope you have a pleasant day. And remember, don't let the rhythm get you. Bye now.